There's a few people on the phone. Get us all nervous.
Hi. So I haven't met all of you like formally. My name is Regina Graham. I am the medical director for the consultation liaison service for the Department of Psychiatry, and I've been involved kind of only in the past couple of months about the whole JCO rollout of suicide mitigation screening. That's basically a national requirement for JCO accredited hospitals. And so I want to talk more a little bit about suicide in general in youth, and also specifically about the ASQ and how we're planning to use it here. So the objectives of the talk are to talk about the scope of the risk of suicide in young people, why there is this mandate to do universal suicide screening in medical settings, and then the risk and benefits of doing this screening, as well as thinking about how to use the ASQ. So, questions you guys, I'm sure, have already asked yourself. Why am I being asked to do this? Last year, the Joint Commission came up with the National Patient Safety Goal, which requires all Joint Commission accredited hospitals to do something to reduce the risk of suicide, not just psychiatric hospitals. And so that includes screening all patients, so universal screening for suicidal thoughts using a validated tool, and then also for staff to be trained to do suicide screening and assessing their competency in doing this. So another question, does suicide affect the young people who are coming to Children's Hospital? I thought this was the Children's Hospital where you know, people come for fractures and traumas. So actually, this has been studied, and unfortunately, medical institutions are basically the safety net right now for mental health screening and treatment. And between 2008 and 2015, the amount of visits to children's hospitals for suicidal thoughts have actually doubled nationwide in children's hospitals. So we're not the only ones. And unfortunately, suicide now is the second leading cause of death for young people between the ages of 10 and 24. So hot off the presses from the CDC, this is actually looking at the rates of suicide in children between 2000 and 2017, so for the past 17 years. And unfortunately, I mean, these are unfortunate. These are unfortunate that children are dying, period, from violence. But in around 2010, actually the rate of suicide is outpacing the rate of homicide deaths for children. And really, this really started happening around 2007, so for the past 10 years. And that is even accelerated faster over the past 4 years. So this is not good news at all. When you break this down, the biggest increase in suicide among youth are actually between the 10 to 14 age group. So even though it was actually pretty stable and going down between 2000 and 2007, over the past 10 years, the rate has actually tripled. And then when you look at between the ages of 15 to 19-year-olds, the rate has actually increased by 76% over the past 3 years for the ages 15 to 19. So I did want to play this video, which is a study that was recently put out that talked about visits for psychiatric concern in the emergency room for children ages 6 to 14. And this is actually like a video abstract from pediatrics. There's my pointer. Okay.
Hi, I'm Dr. Luther Cowell, Assistant Professor at Kennedy Krieger Institute at Johns Hopkins Bloomberg School of Public Health. It is estimated that about 1 in 10 youth in the United States suffered from a psychiatric disorder, and many of those children, unfortunately, never received treatment. So the emergency department has become a safety net for youth without a mental health provider or services. So understanding changes in those issues is important for preparing for care in the emergency department, but for understanding changes in population health. The first objective was to examine changes in psychiatric emergency department visits across the United States among youth 6 to 24 years of age. The second objective was to examine changes in those trends across different age groups, gender or sex, and race. And the third objective was to examine what's associated or correlates of those visits. Particular attention was paid to self-injury or suicide-related visits, especially within adolescents. So between 2011 and 2015, emergency department visits for psychiatric concerns increased across the nation. The biggest increase was in 2015. Young adults aged 17 to 24 years of age had the most amount of psychiatric emergency department visits in the United States. And there was a slight increase in trends over time. However, the largest increase in visits over time was among adolescents and non-white youth. Unfortunately, only about 1 in 6 youth who visited the emergency department for psychiatric concerns saw a mental health provider. So consistent with the CDC estimates that have shown that suicide is increasing across the nation, visits to the emergency department for suicide or self-injurious related behaviors is increasing as well. However, it only increased among adolescents, but it was a large increase. There's about 2.5-fold increase in those visits between 2011 and 2015 among adolescents. Only about a third of these youth who visit the emergency department for suicide or self-injurious related concerns receive treatment. So rising emergency department visits for mental health concerns is not a new phenomenon. It's actually new to us. We don't really know why, but there could be a lot of different reasons. It could be greater recognition by emergency department staff. It could be increased screening efforts. It could be greater reporting by the child or their parent, but it also could signal important changes in population-based mental health. Either way, adolescents clearly are a population at risk for suicide-related visits, and young adults clearly are at risk for substance abuse-related. This suggests that greater intervention is needed among these groups. It also suggests that we need greater expertise to address these specific problems among these specific groups in the emergency department. There are promising efforts going on nationally to improve the quality and quantity of mental health care in the emergency department. These findings clearly support those efforts.
Okay. Okay, so sorry, technical difficulties. Question people always have is, if I ask about suicide, is that making things worse? Isn't that gonna make someone feel even more sad, or possibly even put the idea in their head to actually kill themselves? So there's been multiple studies that have looked at this, and this is just a myth, it's not true, that someone who was totally not thinking about suicide, if you just say the word, that all of a sudden then they think, oh, that's a good idea, let me go do it. Doesn't happen. Part of what led to this whole Joint Commission requirement is actually suicide has been a sentinel event that's been noted in hospitals over the past 20 years. And they when they've gone back and identified what were the reasons behind this, they believe that is due to lack of proper assessment and screening for suicide when someone was initially admitted to the hospital. The places where they have already started implementing screening and the ED for suicide has been found to be acceptable to patients and their families. And they say not disruptive. They probably had a more private place to ask questions, but sorry.
That's what they said.
So continuing related to this, about 2 million youth in the US attempt suicide each year, and actually only 90% of these attempts are actually known by parents. So when you hear parents say, well, I would know if my kid was suicidal, maybe, maybe not. Definitely, obviously, early identification is key to prevent suicide attempts or completions. However, a lot of times, because you guys are attending to physical health, it's not necessarily picked up unless asked directly. And I'm sure everyone's heard the statistics that the majority of people who die by suicide have actually seen a health provider within the 3 months prior to their death. So because of the person may just present talking about how they physically feel and don't, unless someone directly asks them about suicide, reveal that, it could get missed. So, you know, you got nurses, anyone in the medical profession can make a difference in someone's saving a life by asking about suicidal thoughts. And for over 1 million youth each year, going to the emergency room is actually their only contact with a healthcare provider. And so them coming here provides an opportunity to do screening for suicide. Okay, so the validated screener that's been chosen for many of children's hospitals, West Bay and East Bay, is the ASQ, which stands for Ask Suicide Screening Questions. It's 4 items for kids 10 and up, and it takes under 2 minutes to actually do the questions, ideally. So this is Lisa Horowitz, who works for the National Institute of Mental Health, and she actually developed ASQ, so I just want to hear her talk about it. She does a better job than I could.
We believe the medical setting is a wonderful place for suicide prevention. That if we can have universal screening in the emergency department, in the inpatient medical unit, in the outpatient primary care settings, that if physicians and nurses start asking kids about suicide risk, that we could actually reduce the suicide rate. Kids who have chronic medical illness and are in the hospital, that's a good time to ask them if they're having thoughts of suicide, because they have a lot of risk factors for suicide. So we created this screening instrument, and the way you create a screening instrument is you take a bunch of candidate items. So we had 17 candidate items, and then you take a gold standard suicide assessment. And you whittle down these candidate items until you have the fewest number of items that can capture the same kids that the gold standard suicide assessment captures. So that's what we did. These triage nurses really needed to find out who was in immediate danger, who needed further assessment, who was okay. So we gave them a 4-item tool that captured the same kids as a 30-item suicide assessment. Now what we're seeing is that some hospitals are actually starting to implement suicide risk screening for all the medical patients, so universal suicide risk screening. And so what we're doing now is we're consulting with implementation, and we're trying to develop evidence-based guidelines for algorithms. And this is how you implement a suicide risk screening tool so it doesn't overburden your system, and so it's feasible, and so that you can carry on with this suicide risk detection that doesn't overwhelm your regular hospital work.
Okay. Okay.
Exit again. And then just go to the next one. Go to the next slide before you play.
Okay.
Slideshow.
Okay, so quick facts about the ASQ. It was developed in 3 different pediatric EDs. It's designed to be used by non-mental health clinicians. As I said before, it takes less than 2 minutes to screen ideally, and it is available in multiple languages if needed. Dr. Horowitz, she has a longer version where she talks more in detail about how to use the ASQ. It's on the NIMH website. It's about nearly 40 minutes. But I just wanted to, if anyone ever wants to have 40 minutes to spare downtime, you could go and look at it.
We actually use this as kind of a launching point for our tool to educate the nurses. So.
Okay, gonna try to enter. So go to the next one.
This one.
Uh-oh. What did I do? Awesome. Okay. So the details about how it's going to look in Epic, I'll leave that to you guys to talk about, but it will be in Epic. The idea is to ask the parent to, or the caregiver to step away while the screening is being done. However, if the parent or caregiver says no, they want to stay there, that's okay. You can still ask the ASQ questions with the caregiver next to the child. If the child isn't able to answer the questions due to being unable to communicate, they're comatose, whatever, then when the child is alert, and that could be on the floor, the ASQ is supposed to be done at that time as well. Okay, so there's 4 questions. I see that you guys have the actual ASQ form. There's 4 questions on there, which I'll show in a second, but if the answers to all 4 questions relate to are you having suicidal thoughts, basically, if they're all no, then that counts as a negative ASQ screen. If they say yes to any one of the 4 questions related to suicidal thinking, then there's a 5th ASQ question that's asked, which is basically, are you currently feeling suicidal? And if that answer is yes, then that counts as a positive acute positive ASQ, and at that time, the algorithm is that birth precautions are supposed to be instituted and the birth clinician contacted to do a further risk assessment. If the child says no to the 5th ASQ question, which is basically saying they're not currently feeling suicidal, then that is a non-acute positive ASQ, and then that requires further screening from social work or mental health clinician. We're working on those details right now. But this is a little overview of the workflow. Nursing at triage to ask the first 4 questions. Then we talked about basically it's either negative, or if it's one of the first 4 are positive, by responding yes, then you ask the 5th question, and then that goes into either being a non-acute positive or an acute positive ASQ screen. Any questions about just that flow? Okay, we're getting to it. Actually, I don't know if you could pass the tool over.
Everyone has one in our packet.
Okay.
Need this packet?
Yeah.
Where you did, yeah.
I mean, I'm gonna get to it, but if you need to know right now.
Okay.
So there is a script for nursing staff to approach the ASQ. Basically generalizing that this is national safety guidelines, that we have to screen all kids for suicide risk. So just letting them know it's not based on how you look or anything we're reading into your relationship with your child or how your child is feeling. This is just a safety guideline that the hospital has to do because we're a joint commission accredited hospital. And we like to, well, I don't know about the privacy part, hopefully a private corner in triage, and that letting the parent know, the important thing is that although we would prefer the caregiver step away and we ask the child in private, if there is anything that's positive, that we will let the parent know after we're done with the screening.
No one will argue it's sensitive service, is what I asked.
Oh, okay.
If a patient's suicidal, at that point,
Yeah,
confidentiality
that's broken.
goes out the window, and because of that, and because the parent is responsible for keeping their child safe and also being aware if they're being sent involuntarily somewhere, no longer confidentiality applies. If it's because it's a sensitive service when they're receiving mental health services for like depression or something like that, but this is not a sensitive service if they're suicidal.
At Highland, there was a young girl who was 17, and the next thing her mother knew, this isn't me. I have a friend. No, it wasn't. I'm just kidding. But I heard about it, actually. And her 17-year-old, she brought her in for asthma. And they did the screening questions. I didn't mean to call it Highland, but that's where it was. And 17 years old, asked the mom, the mom brought her in for asthma. They did the screening questions. She answered a number of them in a positive way, enough that they were concerned, because she answered them a certain way. Literally the next thing the mother knew, the ambulance was taking her out to John George. And truly, and they said it's a sensitive service and we can't tell you that she's suicidal, basically. And that's what they said. They said she's protected and for a sensitive service. Child 17.
So here's.
I just want to make sure, you know what I mean? It just recently happened, maybe 4 months ago.
Correct. So I'm not.
I know, no one's making a judgment. I just.
But you can't go to John George unless you're 18 or older. So I don't know if that was part of it. Was they were protecting her confidentiality because she was over 18. And that's why they weren't telling
She might have just been 18.
Yeah.
You're correct.
Yes.
Okay, so that takes care of our sensitive. I just get concerned, we get barraged about the sensitive service of psych emergency, but okay, I get what you're
So
saying.
the one thing that sometimes that we don't disclose to parents is that they're saying I'm suicidal because my parent did such and such. So
Sure, I hear it, or cutting, or that kind of thing.
that kind of thing. But when somebody's a danger to self or others, confidentiality's out the window. We write
Except
up
if you're
the
over
voluntary
18,
hold.
which some of ours
Yes.
can be. Okay, I understand. That's,
And if you're over 18, we can't discuss anything about the child's
Sure.
sensitive service or otherwise.
I think that might have been the rub, actually.
Yeah.
Okay.
And that makes a lot more sense. But if for a child that's close to suicidal ideation, we do make the parents aware that this is because they said something about danger to self or others, and this is what we're doing. They're going to see a security by the door. They're going to see all these other things, and they need to be aware that this is what's happening. And when we go in, we tell the patient that this is what we need to tell your parents.
That's really
because we need to make sure that you're safe, and keeping you safe involves having your parents communicate and collaborate with us in doing so.
The nuance is, though, at triage, the kid's 18. We have to be, okay, cool. That's very helpful. I was looking for that. Exactly.
And forgive me if you're going to speak to this already, but these scripts for the nursing staff has right on here that if it's positive, it has a script for the nurse about what to say to the parent.
I am gonna guess that, yeah.
Yeah, that's perfect.
Yeah.
That's great.
But thank you.
Yes.
Okay. What are the questions?
What are they?
So, they kind of go to sort of more general, just wishing you're dead over the past few weeks, to have you actually had an attempt, to, or right now, are you having those thoughts? So, you can kind of see it's kind of more general, and then we're kind of narrowing down on the rest. All that being said, this tool is overly sensitive, so there will be people who will, the way it's written, it catches more people who seem like they're suicidal, who after further assessment, they actually are not. But, it's supposed to be for safety, so they're thinking to capture more people who maybe will end up not being high risk, however, just catch everyone, or as many people as possible who could be at risk.
And we're supposed to be asking verbatim.
Verbatim. Yeah.
It's gonna be a big change.
Yes.
That's true.
Yeah.
It's not comfortable to ask people, you know.
No.
no
And
matter
especially
who.
with the kids sitting on the parent's lap or sitting near them.
Oh, especially then we oftentimes get kids who won't say a thing.
Yeah.
Then
Well,
we do
then
that.
you don't have a response, right? With
That's
this, then it's,
considered a yes.
So, yeah, so
No response is considered a.
We'll go through
But
that.
we'll go through that. I mean, but yeah, the idea is to ask the caregiver to step aside so you can talk to the child in private. However, if a parent says no, they want to be right there, then proceed with asking the questions. So ideally, the parent wouldn't be there, so it would be less awkward, but.
the window for us is the 10 to 13 crowd. Like a 10-year-old generally doesn't come to the ED
Yeah.
expected to be separated from their parent and vice versa, right?
Right.
Yeah.
You'd be hard pressed to get them.
Yeah.
To separate.
Great.
Yeah.
All right, we still do it. I mean,
But we can still also say it's gonna be 2 minutes.
I would not allow my child to be separated even for a minute,
Yeah.
given the option,
Mhm.
right?
Especially if they're in pain or throwing up.
Exactly.
Yeah, yeah.
I mean, that's fine. Yeah, if they're in for a behavioral emergency, I'd be very different.
Yeah. Okay, so the scripts, what if this positive? So the script they provide is, I'm so glad you spoke up about this. I'm gonna talk to your parent and the medical team. Someone who's trained to talk to kids about suicide is gonna come talk to you.
Okay.
That's your opening to introduce us. And then in terms of if it's positive, saying to the caregiver, we have some concerns about your child's safety that we want to further evaluate. And that you're gonna, have someone who's trained to come and talk to your child about suicide based on the screening. So that's it. So I know it's stressful. It also, I think the idea is to kind of take it off of you guys, that this is just a screen, it shows something concerning, and then someone who's more, specialized in this will further evaluate your child. But I'm not saying right now you triage your child to going to a hospital. This is just a screening.
I'm concerned over left without being seen at this point.
About what?
Bringing a 10-year-old for fever and cough, and then their kid says something, which is for a safe life.
If it's an acute positive or a non-acute positive, we don't put them back in the lobby.
No, I know that. And they leave the room. We have people leave all the time from the room, leave without being seen. That's all I'm concerned about. Oh, crud, what did we just say? We're out of here. And then we end up with a medical condition that's gone home. We will watch that metric and just see if we have a problem.
Yeah, and I think.
I'm not borrowing trouble. I think there's a way to present it.
And I think any of that information is also really helpful for us to,
Oh, I report it every day, yeah.
for us to eventually problem solve and figure out ways that we can get more resources and other things that can be set in place to prevent people from leaving or to.
Because as soon as you come in and go, we're not concerned about your child's safety any longer, the whole thing is unraveled. They start being met with strangers in their mind.
And also, what Dr. Graham said about if it's a non-acute positive,
Non-acute positive.
does not have precautions.
Correct. We don't
So-
go 5-5 bird. Of
That's
course.
even more of a risk for people to walk out.
Of course, that's what I'm saying. We're gonna have someone come talk to you because we're concerned for your child's safety.
While waiting for social work to come. Yes.
That half-hour window, the resident has gone in and said your child has strep throat, and they want to go home now, and then they leave. So then we have a non-acute positive who's left without being seen, but has left with a prescription because they were seen quick enough in annex. Right, because this is for annex too, of course.
Mm-hmm.
Right? Even though our policy says no bird can go to ED annex.
But they're not birded.
They're not
No,
burdened.
no, I totally hear that, but no behavioral complaint actually is allowed to go.
Well, and if it's a non-acute positive, they're a triage category 2 and may not go to Anna.
You hear what I'm saying?
Even if their chief complaint is a stub toe.
I totally hear that. So we're gonna have to watch that. Because we will exceed our capacity in a blink.
Really
Well,
quickly.
And I think, like Marisol said, to communicate that and for us to communicate with the powers that be to give us more resources.
Well, we don't physically have the rooms to do that, right?
Agreed.
Right? Because right now we have 2 or 3 births in our department and everyone else is medical. You know what though, we have to hear about this and we know what the statistics say. It'll be interesting. The acute positives are very obvious. That won't change at all. Those are the people that we expect and put in rooms and da-da-da. It's the ones that answer yes to these who could quickly be screened into not a serious emergency, have somewhat been put up the acuity chain.
And that's exactly what Dr. Graham is saying. Those are the resources we're asking for.
That's exactly correct.
Yes,
Because
so
we
the
can't,
more we hear,
yeah, quite frankly, we can't, I shouldn't say we can't allow that, sounds totally wrong, but you get my point. If you have someone not breathing in that, you're like, well, crud. And you can't put them in the hall like they do in other facilities. It's gonna be an interesting thing.
So anything that advocates for more resources for those non-acute.
We need more right now for acute. Call out.
Yeah.
Well, yeah, that's exactly another.
You'll get no argument from them.
Yes,
That's for sure.
that's exactly
Okay.
what we're. So we are also concerned about the acute as well,
Yeah.
because it will highlight some acutes that we are missing right now too. So we're getting an increase in that as well. But
That's
and
kind of
the non-acute could become acute after speaking to a social worker that spends more time with them. So that's also going to increase. So we need more resources already, plus more that we're gonna need, and also the resources that we need for the non-acute. So any evidence of that can support our request for that, we would really appreciate.
Because we're world-class hospital.
Yeah, I know that. I looked on my badge earlier. Oh, Lord of mercy.
How do we respond to the parents that won't leave the screening, let's say they've got a 10-year-old, and they're angry that we're asking those questions? Because I know we're gonna get those.
Well, we already got
get them.
We got 3 years of angry when we were asking them about HIV testing.
Right, yeah,
Yeah, and I liken this to HIV.
That, me too.
because
I
it
mean,
was
they
very
were-
uncomfortable initially, but it's become part of our process.
And our HIV compliance went right down.
Yes. So it is repeating that quote that this is, what was
National safety.
I think it's fine. National patient safety goal.
Can we have a sign up in the lobby that says, do
No.
natural patient goals?
No. It's considered coercive for one.
Well, that's what it seems very coercive. And
Well, no, I think screening, we don't want to miss an opportunity where they went home and killed themselves, because we've
Right.
had a couple of late at almost the exact gig. And like you said, we're seen within days of being seen by a clinician. You know, and we have the people who trial balloon. They come in with a sore arm. They come in with a no. And we don't want to miss those, Marie. I get it. It's just going to be how we communicate it to parents to A, not have them vote with their feet, which I'm worried about, right? Because that happens with non-accidental trauma as well. As soon as they have a social worker sniffing around, they're by.
would it help the parents' anxiety if they knew what questions we were asking them? Is
Well,
that-
they're going to hear them, I think.
Yeah, and we could ask them, questions if the parent doesn't want to leave. We can ask the questions.
Most kids don't make the parent leave.
Yeah.
Truly, most kids don't. They don't. They don't want to be separated from their parent.
Yeah.
Most kids don't.
the reality is that most of these questions will be asked with a caregiver present.
Yeah.
That's the reality.
I think so too. And they'll hear their kid, quite frankly, for the most part, I think, answer negatively. And as a parent, if your child answers positively, you should be grateful. Right?
Yeah.
Well, they'll never be
So
grateful.
one parent that said, oh, she always lies, I'm like,
Well, there's,
yeah, there's always an outlier, right?
That's not your problem.
Yeah,
I
right?
mean,
Yeah.
we'll sort that out. And
Moving on.
without a kid who's lying about that, that's about your pay grade.
yeah, no, it's fine.
So I really like this. This is a little video about teen suicide prevention, but it's the teens themselves talking. So I feel like this is like a good place
The
to.
girl on the right, a little questionable. Her hair choices, pants choices.
Just like
She is? No, I'm just kidding.
maybe more than I can be hard to figure out.
And I like my privacy.
I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual,
Acting really down, crying all the time for no good reason.
or getting really mad, not able to sleep, or sleeping too much,
Shutting our friends out or giving our stuff away.
acting reckless, drinking, using drugs, staying out late,
Suddenly not doing stuff he used to love.
or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed, not just feeling down, really depressed.
It might be that your kid is thinking about killing himself.
It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said
I
something.
wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask.
They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask. In fact, the best way to keep a teenager from killing herself is to ask. Are you thinking about killing yourself?
And what if they say yes?
Or,
Or sometimes,
well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
you're making too much of this.
That boy's not worth killing yourself over. That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself.
What you do say is,
I'm sorry you're feeling so bad. How can I help? We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves, adults and kids.
most of them never try it, but some of them do. So if your kid says,
I'd be better off dead. Can't live with this.
I'm gonna kill myself,
Take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure. But sometimes it goes deeper, and it's not going to go away by itself. Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
but don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts. Make a list together. Write down 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Make sure your home is safe. If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. Bullets too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask. Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut.
Because it never hurts to ask.
And it can make a big difference. All the difference. In your kid's life.
Okay.
That is terrific.
That's a really good video.
They're like normal people, meaning they're not like way out there. People, okay, my kid would never look like that or whatever.
Yeah.
You know what I mean?
Yeah.
And I don't,
And really simple advice.
yeah,
That is simple to follow.
simple to follow. That's very, so how, oh, we're not gonna play that
That
anymore?
video makes this make more sense.
It's really.
That's why I'm trying to.
How do you
That's my
disseminate?
point, I'm trying.
I've never seen it on TV at all.
No. No.
I've seen it like on dumb talk shows that, who's home during the day? Nobody. You know, maybe the kid is, but.
It's helpful for parents to have more access to some of these things. We are working on that.
Yeah.
Maybe loading a video like this.
That's what I was thinking.
We can. Yeah.
While they're here,
Mhm.
even if they're a negative, just have every.
I don't find that negative, is that being negative?
No.
Even if
I'm saying
The
that
screen,
if
the screen, just to have it as
They
an
may have a
option
cousin
on
or
their.
somebody who's not even anything to
Yeah.
do with them.
Well, maybe the parents could watch it while we're talking to kids. Like when the
I mean,
social worker's talking
You
to
know,
kids.
posters are not helpful for us.
Yeah, I can.
It's just like the HIV posters. They were about as helpful as not at all. You know, no one looked at them and go, oh, it should be tested. I mean, that, nobody did that.
Maybe uploading it to the TV channels that we have here or something.
I think they're exceeded, but we can put it on the iPad.
We could definitely put it on the iPad.
So thank you for that. That was good.
I don't know about.
And that's just on the NIMH.
Yes,
HMI.
Whatever that
website.
Yeah, and it's Mayo Clinic, so you can just say Mayo Clinic team,
Okay.
suicide prevention. It is on the NIH website, but you can just search that. Anyway. So it's test time.
There's a test?
These are the questions that were uploaded, right?
Yeah.
Yep.
Okay,
All right, so you could get, you could fail this test, but on the real one, the health stream, you get it all
The
right.
health stream, you'll know what's missing.
Exactly.
Is
All
that
right.
As soon as Crystal.
Oh, jeez.
Question one.
Thank you.
The 10th cause of, yeah, that's the answer.
Okay, go.
True or false?
All three. Nothing, trip up.
False, the second leading cause of death for 10 to 12.
For somebody that didn't watch or listen to the
Okay, library, but you're gonna have to take this test on the HLC.
This is, yeah, good.
So it's false.
Yeah, it's false.
Yes.
It's
Well,
the
yeah,
second leading cause.
All right, question two. Only birth clinicians or physicians can ask questions about suicide at BCH.
false.
False. Universal screening to be done by nursing. All right, question three. ASQ will be used in the
Yes,
East
true.
and West Bay. True. Yes. See, I'm making this easy. Oh my goodness, you guys already have 100%. Okay, this is supposed to take 20 minutes to
Well,
answer.
2 minutes.
You'll get everyone
Awesome.
5150 on that deal.
You'll be having to call for the nurses to.
Nurse to pick up a nurse at triage?
ASQ
Yes.
was specifically developed to screen for suicide in youth.
Yes, true.
All right. I can't complete ASQ if parent refuses to leave the room.
False. Do it anyway.
That's right.
I read this on the thing you gave me.
Okay, if patient refuses to answer ASQ, it counts as a negative screen.
False.
True. So it's considered positive.
Yeah.
False, it's true.
It's true that it's false.
Yeah.
Double negative. If all four of the first ASQ questions are negative, then I'm done with screening. True or false?
True.
Yeah, I can't trip you guys up. If one of the first four ASQ questions are positive and I ask the fifth question and it's negative, then the patient is done with suicide screening.
I read that on my phone.
Well,
They're done with
the screening's done, but then the procedure.
It's considered non-acute positive.
Yeah,
There you go.
non-acute positive screen.
Exactly. So they require further screening for their safety by social work or mental health clinician or just before discharge.
Right, so they're done with our screening, but not the whole team.
Not
Now it's
suicide screening, not
Got
suicide,
it.
yeah.
Okay, yeah.
They will get another suicide screener by social work that looks different than this one, a little bit more extensive.
All right, last question. If patient is an acute positive ASQ by answering yes to at least one of the first four and then yes to the fifth question, which is are you thinking about suicide right now, then the patient will be placed on a 5150 and transferred to a psych hospital.
No.
Well, no,
They're gonna be
they're
buried.
just buried.
They get further.
They can't leave until they're evaluated for
Awesome.
safety.
So if it's acute positive, then they will be placed on birth precautions and the birth clinician, after they do their full assessment, will determine whether or not they meet the requirements for a hospital.
That part is unchanged in our university.
Yes, yes,
It's just a different.
Yeah.
process, yeah.
Saying it.
But I think it's important to highlight so no one's telling a parent, oh, you're acute positive ASQ, so now your child's gonna go to a
Well,
hospital.
none of this can be said at triage, really. A nurse to pick up a patient.
Right.
That's it, because they're gonna run out the door.
Yeah.
If we're not careful.
The child will.
Yeah. Your first question to me is not a good question because we get so many numbers thrown at us about incidences of this, that, and the other thing. The numbers just fly out the window, they mean nothing. We know it's important, and knowing that whether it's number 2 to second place or 10th place.
Yeah, but Marie, 10
Yeah.
makes it sound so inconsequential, is the truth.
Well,
Right.
and to me,
Yeah.
seeing it up there as the second leading cause of death for youth, that has a big impact.
I think the
remember
way,
that,
at
'cause
least
it's
in
like, wow.
HLC, that they do
Yeah.
things is they don't, this is to follow Marie's suggestion, you want to enforce what the severity is, so you write, it's the second leading cause of death. That way it brings it home and you answer true.
Oh, I got it.
So it gives you a
change-
positive,
yeah,
it gives you an
Okay, no
affirmation
problem. Yeah,
plus
yeah,
an
I could change
Yeah,
that.
that would be a better, yeah,
No problem.
that would stick better.
Okay.
So, no, I do this with the trauma
Yeah.
exam as well.
Is this
Yeah.
the same one that we're loading up onto HLC? Because it's
Yeah.
different to me. Okay.
It's the same. I think I broke it, I don't know. I think I broke it up to, there's more questions on each slide. What I said, yeah,
maybe.
because it hasn't been broken up yet.
Okay, that's fine.
Um,
I think, so just make it be a positive so you answer.
yeah, so, I could change it.
Are you able to?
Sorry?
Are you able to change
We
it?
can reverse. We can,
Okay, I can change it and send it to you.
I've loaded the questions into HLC now, so I'll just kind of
You'll
reword it. So
reword it, okay.
it
Make the
becomes
answer be the
a
question.
Yeah, awesome, yeah. Good point, thank you. All right.
So when we get an acute, non-acute positive,
Yes,
then we're supposed to put these patients directly into a room. Even if their complaint is something minor.
I can't remember what the policy said. I think so. They're a triage category 2, and I think they need to go to, I'm gonna be on the road with this, so.
Is there a reason why we have to make them go and do that? Because we don't want them to go to the lobby. Non-acute positive. That means they've answered, I want to be dead, right? All right, that makes sense then. If they really answer, I
I've
want
been
to be dead. I've been thinking about being
about
dead. I mean, yeah.
I've been thinking about, it would be
I
better.
just keep thinking about the 5th grader who says, I just want to die. You know, like,
Yeah,
my
that's
job
why there's-
is 4th grade.
Yeah, that's why there's
Our whole
more.
class says stuff like that.
Yeah,
Except for when my son, who was in the 4th or 5th grade, because his mother always said, oh, I wish I were dead for everything that went wrong. Said that one time, and we had a whole family meeting about it. And he was just using an expression, thankfully, but
It's fine to screen. I guess we have to see what ends up. If we really end up with 30 patients a day answering non-acute positive, 30 patients is more than our ED. So, you know what I mean? And then the rooms are filled, what do we do with those people? And if we can't bring them to Anna's, oh boy. Why don't we wait and see?
well, okay.
What were you gonna say?
How did that come about?
What
That they can't go to annex if they're not acute?
if they're, yeah.
Well, no behavioral emergencies can, because it's a long visit.
and we're requiring that they get additional screening and assessment. And
It's a fast
thankfully,
track.
we have the social workers that will
Thank you,
help,
Marie.
but,
A lot to get the court box.
so that we're not holding the patients like 1 in the morning till 9 the next day.
It's really a fast track, plus there's pediatricians back there, and the idea is,
Okay, I got
it's really not for that.
it, got it.
If they don't have the nurses.
And if the patient,
Okay,
and if the social worker, the birth clinician's screening and assessment decides that they need to be on birth precautions,
then
we
you have to
can't
move,
do it
you
back
have to
there.
move,
Yeah.
yeah.
That's true. Because social worker
And
might
there's
say
not the
yes.
same,
That's
the other
true.
thing too is there's no observation.
That's true.
I think we have to see how many humanoids this really, the acute thing, like I said, will not, it'll be the effect that we already have. I think it's the non-acute positive that answers negative to the first 4, positive to the 5th one.
They have to answer at least one of the first 4 positively.
But they're negative to the last one, so they're not saying right now I wanna kill myself.
Number 5 is birth. Question 5 is birth, if it's
Yeah.
possible.
We may have to adjust, but
Yeah.
that's what
Be flexible.
the non-acute positive is still a positive screen. We still have to take it seriously. We
And
can't
social
send
worker
them back
isn't
to the
here in the
lobby.
middle of the night.
We can call the social worker in.
Yeah.
And it takes over a half an hour, if not an hour.
Right, but a medical screening exam takes a half an hour.
We'll see. So if it was last night, it'd be problematic. Every room was full. We'll just see. I don't want anyone to go out the door. It's just, you know, that's already the resource thing of what you're
And
saying.
if they do, please let me know, because I'm keeping track of that,
But the go?
if they leave.
Oh, no, I run a report every morning. I don't run it, someone runs it for me. And I always just fever emesis, stub toe. If anything ever says behavioral emergency.
Well, but so the scenario is a kid comes in with abdominal pain and emesis. We ask the questions. They end up being non-acute positive. We're only going to see that they left without being seen with a chief complaint of abdominal pain.
And an acuity of 2. And I review all of those. The 2.
But is there going to be
I
any way
get
to
that.
track?
You're gonna have to. You can open it up. Of
You're going to
course.
have to open up the track. Well, and frankly, our left without being seen policy says if a triage category 2 patient leaves without being seen, we need to follow up with that.
Every single page I've reviewed for a month has not been into.
Right.
So, I mean, we're fine.
And
But
if they get seen for the medical reason and not for the non-acute positive,
we would, if they're a non-acute positive, the policy says we make them a triage category 2, even if their medical complaint would warrant a triage category 2.
Yeah, so
So I think it's gonna take some educating the attendings to mark them as not ready to go until the screening.
yes.
Absolutely. And the policy too, and in the HLC that we made does say that the rooming nurse is responsible for contacting the bird.
Charge caption too, are they getting charged? Not bird, and they're gonna be charged.
I don't know. I mean, anyway, so the rooming nurse is responsible for calling for the social worker and bird clinician, and we're just gonna have good, everyone's gonna have to get used to using AMCOM or having good direction about who to call when.
yeah, I think that's something that needs to be really clear is if number 5 is a no, it's not bird. And
Oh, it's not ever bird?
if it's a no, 5 is what makes it a bird.
No, but I mean, the bird clinician will still get called for a non-acute.
Positive, it's social work.
Okay, so
100% of the time it's social work.
so if we get a non-acute
Perfectly.
positive, we're supposed to call the medical social worker and not the bird social worker. So it starts with them, they tease out whether they need.
They do another screener, and then that screener will either get them the Columbia, they'll either go home or they'll become a bird, and then we would get them a
Okay. All right.
So
If you're in the department with another bird, it's still social work. Gotcha. I did not know that.
non-acute positives are not bird assessed.
They're the social worker. Our problem with that is we have very bold limited yard.
Yes. We would love to have the resource to be able to do those as well.
Very completely. I'm taking care of a
Because-
cook in the ICU. I'm at Summit.
Yeah.
I'll be over there in 45 minutes.
Well, and patient care wise, they get asked by nurse, they get asked by social work, and then we come in. Clinically, that's not what we would want either. So we would love to have that resource to be able to be the ones
Yeah,
to take it.
you know,
all
I think this is like we say all the time, metrics will either set us free or